Hi there, my name is Shauna Gunaratney, and we will be talking about tuberculosis treatment. So first we'll talk about isoniazid, one of the backbones of tuberculosis therapy. Isoniazid, also abbreviated INH, is an old drug first developed in the early 1900s. Its mechanism of action is important to understand. It is activated by microbacterial enzymes, and this activates it from a prodrug into an active drug. This active drug inhibits mycolic acid synthesis and disrupts the mycobacterial cell wall. The prodrug requires two mycobacterial enzymes, CAT-G, which activates INH by coupling it with NAD, and this active INH then binds to its active binding site, the INH-A protein, which then disrupts mycolic acids from forming. Isoniazid is thought to have early bactericidal activity. The reason it is important to understand the mechanism of action is Mycobacterium tuberculosis has unfortunately developed mechanisms to overcome isoniazid. It's developed mutations, most commonly in CAT-G, which is found in isoniazid-resistant isolates. CAT-G mutations confer high-level resistance to isoniazid. The second most common mutation that is seen is in INH-A, again, the binding site of the active drug. This confers low-level resistance, and so one can use higher doses of INH as part of the treatment regimen to try to overcome this. The two isolates together, resistance mutations in the two enzymes, are responsible for the vast majority of isoniazid resistance in the United States. There are other mechanisms of resistance in other enzymes, but they're less clinically relevant. Isoniazid does have some adverse effects. It's important to distinguish the difference between hepatotoxicity and hepatitis. Hepatotoxicity means someone who has increased liver function tests. This can actually be asymptomatic and typically resolves on its own. This is different than hepatitis, which is inflammation, much more serious. This is symptomatic and can be fatal. Hepatotoxicity, luckily, is more common than hepatitis. Hepatotoxicity can be as high as up to 22% in people receiving INH. Hepatitis is much rarer. About 0.5 to 1% of individuals on INH can develop a hepatitis. The risk of liver injury is associated with increased age. So especially age over 65 years, those people have a higher risk of liver injury with isoniazid. Concomitant alcohol use can also increase the risk of liver injury with isoniazid. Someone who has viral hepatitis, for example, hepatitis B or C, has a higher risk of developing hepatotoxicity or hepatitis with INH. Those who are slower metabolizers of INH are at increased risk. And also when INH is used with other medications that cause hepatotoxicity, such as pyrazinamide, this increases the risk of adverse effects on the liver. Another important adverse effect is neuropathy. Isoniazid actually antagonizes pyridoxine, vitamin B6, by binding and interfering with its activity on neurotransmission. So as a result, peripheral neuropathy, so tingling, numbness, burning pain in the hands and feet can be seen in up to 1.2% of people who receive INH. It's much rarer, but central nervous system adverse effects can also occur. Risk factors for developing neuropathy include increased age, diabetes, chronic kidney disease, alcohol use, and pregnancy. Conditions that can predispose one to neuropathy to begin with. So in those patients who have risk factors for developing neuropathy, we recommend giving isoniazid along with vitamin B6 or pyridoxine. Drug-induced lupus, finally, is a rare complication and adverse effect of receiving isoniazid. Next, we'll move on to rifampin, otherwise known as RIF. Again, another old drug developed in 1966, and its mechanism of action, it inhibits RNA synthesis of Mycobacterium tuberculosis. So the most common RIF resistance mutation that's observed is in the RPOB gene. Greater than 95% of RIF resistant isolates have a mutation in this area. And this allows rifampin to not be able to bind to the Mycobacterium tuberculosis, so then it can evade the rifampin activity. Rifampin resistance is also a helpful marker for multi-drug resistant TB, or otherwise known as MDR-TB. Greater than 90% of rifampin-resistant TB is also resistant to INH. So our gene expert tests also test for rifampin resistance in the RPOB gene. Some adverse effects of rifampin include red-orange discoloration of body fluid, for example, urine, sweat, tears. This is not harmful, but it is important to counsel patients so they do not become alarmed when taking rifampin. Rash is actually one of the most common side effects. Up to 5 to 10%, 5 to 10% of individuals receiving rifampin can develop rash. GI side effects can be observed in up to 9%. Luckily, rifampin is lower risk for hepatotoxicities than some other drugs such as INH. Rifampin can also have effects on bone marrow suppression and the CBC with differential. Thrombocytopenia is actually the most commonly observed hematologic effect. You can also see hemolytic anemia and neutropenia. Rifampin causes significant drug-drug interactions because it induces the cytochrome P450 enzyme pathway. And so this will increase metabolism of many drugs and decrease circulating levels of drugs. For example, warfarin, steroids, oral contraceptives, sometimes anti-epileptic agents, etc., antiretrovirals used to treat HIV. So this is very important because drugs may not be able to be used with rifampin, or if they are used, their doses may have to be adjusted to overcome this. Next, we'll move on to pyrazinamide, otherwise known as PZA. Its mechanism of action is not fully known. There are multiple proposed mechanisms of action. It's thought that it acidifies cytoplasm, can inhibit fatty acid synthase 1, which blocks mycolic acid synthesis. It is active at acidic pHs, and PZA, like isoniazid, is also a prodrug. It is converted to an active drug, pyrazinoic acid, by a mycobacterial enzyme. Pyrazinamide is active only against Mycobacterium tuberculosis and not other non-tuberculous mycobacteria. So again, here's an example of some proposed mechanisms of action of pyrazinamide. So important resistance pathways. So the PNCA gene in Mycobacterium tuberculosis encodes that pyrazinamidase that is required to convert the prodrug to the active drug. So resistance can be seen in this gene that allows the bacteria to become resistant to pyrazinamide. However, pyrazinamide resistance is quite rare. Pyrazinamide is important because it has significant sterilizing activity. And when it is used in combination with isoniazid, rifampin, and ethambutol, because of its significant sterilizing activity, it is able to shorten the treatment duration from 9 months to 6 months of total therapy. If pyrazinamide is not able to be used due to some of its side effects, which we'll talk about later, then treatment duration needs to be extended to at least 9 months of therapy. Pyrazinamide can have adverse effects such as hepatotoxicity and hepatitis. The rates of hepatitis here are higher than what is seen with isoniazid. It can be up to 2.5% of individuals receiving pyrazinamide. It is dose dependent, so it is increased risk of hepatotoxicity and hepatitis with increased doses. The risk also increases with age, or if there's underlying liver disease, or if it is paired with other anti-TB drugs that are also hepatotoxic, such as INH. A common observation is hyperuricemia and sometimes gout flares in people who have pre-existing gout. Up to 86% of individuals can develop hyperuricemia because the active drug actually competes with uric acid at the kidneys and prevents excretion, and so uric acid can build up. Unrelated to this, people can also develop arthralgias, up to 8% of those on pyrazinamide, and a rash is also something that is observed. Finally, we'll talk about ethambutol, otherwise abbreviated as EMB. It was discovered in 1961. Its mechanism of action previously was not fully known, but now it is thought to disrupt mycobacterial cell wall and interrupt synthesis. Ethambutol binds to certain enzymes such as EMBA, B, and C in the organism and inhibits their activity, and it also interrupts carbohydrate polymerization. So as you can predict, the most common mutation that confers resistance to ethambutol is in one of these genes. It's in the EMBB gene. The most common, most important adverse effect to know associated with ethambutol is optic neuritis. Luckily, it is lower risk of developing this at the doses used for TB. It often manifests first with loss of red-green color vision and typically is reversible when stopping the drug. So all patients who are started on ethambutol should get a baseline retinal exam, and patients on ethambutol should be tested monthly with Ishihara color plates for red-green blindness at their monthly visits. So we can pick this up quickly before it progresses and when it's reversible.